Management of fistula and ano involves a multidisciplinary approach that includes accurate diagnosis, classification, and appropriate surgical or non-surgical treatment to promote healing, prevent recurrence, and minimize complications. Here is a detailed overview. Hashtar 1. Diagnosis. Accurate diagnosis is crucial for successful management. It involves history and physical examination, history of recurrent abscesses, pain, discharge, or swelling near the anus, inspection for external openings, induration, or discharge, digital rectal examination to identify the internal opening and assess the tract. Imaging modalities: MRI, magnetic resonance imaging, gold standard for identifying complex fistulas, multiple tracts, or abscesses. Endoanal ultrasound, useful for evaluating fistula anatomy, particularly in simple cases. Fistulography, rarely used, involves injecting contrast into the fistula tract. Proctoscopy or sigmoidoscopy, to identify the internal opening and exclude associated conditions such as inflammatory bowel disease or malignancy. 2. Classification. The treatment approach is guided by classification. Park's classification: intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. Simple versus complex fistulas. Simple, low, single tract, and not associated with complications. Complex, high fistulas, multiple tracts, or those associated with abscess, Crohn's disease, or prior surgery. 3. Treatment options: non-surgical management, medical therapy, mostly adjunctive, antibiotics for infection, e.g. metronidazole, ciprofloxacin, biologic agents, infliximab, for fistulas associated with Crohn's disease, immunosuppressive therapy, e.g. azathioprine, for inflammatory conditions. Seton placement: loose seton used to allow drainage and prevent abscess formation. Cutting seton gradually cuts through the sphincter to promote healing in high fistulas. Surgical management: fistulotomy. The tract is laid open to heal by secondary intention, best for low, simple fistulas to avoid sphincter damage. Fistulectomy, complete excision of the fistula tract, associated with longer healing time but may reduce recurrence. Advancement flap procedures, used for high or complex fistulas to preserve sphincter function, involves covering the internal opening with a mucosal or rectal advancement flap. Ligation of intersphincteric fistula tract, lift, a minimally invasive technique where the fistula tract is ligated in the intersphincteric space. Plug or biomaterials. Biologic plugs made of collagen or fibrin glue are inserted into the fistula tract to promote closure. Video-assisted anal fistula treatment, VAFT, minimally invasive technique using a fistula scope to identify and seal the tract. Treatment of recurrent or complex fistulas. Combined therapies may be required, such as seton placement followed by definitive surgery. Management of associated conditions, e.g., Crohn's disease, malignancy, is essential. 4. Postoperative care and follow-up. Wound care: ensure proper cleaning and dressing of the surgical site to prevent infection. Pain management: use analgesics and stool softeners to reduce postoperative discomfort. Diet and lifestyle modifications: high fiber diet to prevent straining during bowel movements. Regular follow-up, monitor for healing complications, e.g. incontinence, recurrence, and patient satisfaction. Complications to monitor: infection or abscess formation, recurrence of the fistula, fecal incontinence due to sphincter damage, strictures or delayed wound healing. By tailoring the management plan to the individual patient's condition and fistula complexity, optimal outcomes can be achieved with minimal complications.